All right. Um, so this is one of the most impressive charts, I think, in cancer, in the war on cancer. And I just want to point out that that 10-year line and that nice 80% 20-year line, uh, one of the big differences between them was that there wasn't a management system being used. And LCAP has always, thanks to Tony, thanks to many others, had a evolving management system. And I'm happy to report that that management system now has been deployed in the VA and has been moved out to, well, is being moved right now to Ethiopia. I'll get to that in a minute. But we call it Screening Plus outside of the VA. Inside the VA, we're calling it now VA uh, LCAP. And we're taking the best practices of 25 years of LCAP and putting it into a web-based management system. And if you think of screening as a pipeline where you're collecting data and you're monitoring performance throughout the entire pipeline, there's numerous opportunities for both problems to arise as well as the ability to interrogate the data and optimize the output, the outcome of the screening, let's say, program. And one of the big things that's happening these days is we've been adding AI. We've been giving the AI, basically, we've been filling out what we call the CT eval form with AI results. And we've been working with various industry partners, including Siemens, as well as recently now Mevis, to fill out uh, basically CT eval form and automatically create uh, basically CT reports. But I want to point out, and I wasn't like I'm not trying to say AI is going to take over the world, but it will take over the world. What I'm trying to get at is that each element here is collecting so much data. There's no human can look at all of this and optimize it. And everything from risk assessment coming into this process to advising the technologist to advising the scanner what to do, what protocol to apply. Uh, of course, the radiologist, uh, as well as even the people downstream, interventional radiologists and surgeons, they're all going to have parts of AI solutions, and they all have to be integrated and working, not just with each other, but with the machines and the equipment and the phantoms and everything else. So we're just right now focused on this bottom AI that I show here under diagnostic radiologist, but be assured it's going to happen across this whole spectrum. We do have funding now from Bristol Myers Squibb to take the system and deploy it in Ethiopia. I have the servers actually spinning up right now, and we're setting them up, and we're about to ship them. And we're all heading, the LCAP team is heading over to, I can't stay straight up here. Sorry about that. The LCAP team is heading over to Ethiopia real soon. Now on to calibration. I've been working in calibration since 2002. I designed the first AD&I Phantom back when I was leading AI for GE. And we've been steadily progressing. We even created a PET CT pocket phantom, a radioactive phantom. And, and I'm happy to say that the work we've done with Kiba and CTLX-1 and CTLX-2 phantoms now are becoming a global standard. They're across all, I think, virtually all continents now, almost except for Antarctica. And we need to address this question as to when we see changes, like you see here, is this a real change or is this not a real change? And the only way to do that is to, that I know of that's reliable, is to really fully understand the precision of both the acquisition systems, the image formation essentially, as well as the software itself. And if you do understand that, then you can do far more interesting things. Now, here is an example of, from the LCAP group, of taking 0.625 millimeter, basically multiple scans of a nodule, subtracting them and getting a change in terms of volume. I'm sorry, volumetric percentage. So the vertical is volumetric percentage. And what you're seeing here is that we've got models that we've developed over many years to fit to what the error is associated with, doing a volumetric change measurement. And you can see that as we get down to, can I do anything here? No, I can't. Hold on a second. As you get down to around 6 millimeters, this thing really spreads out. And things can even get much worse than that if there's movement or there's other things going on. But if you're using, most of the world doesn't use 0.625 or 0.5, they use 1 millimeter or 1.25. And if you're doing that, then you get this wider set of curves that we use. This is the table for the Kiba small lung nodule profile. So this is the main problem that we're dealing with, is that the volumetric change, if in kind of a worst case scenario, can be quite large. And going back to the images that I showed you before, that can cause real havoc as to whether or not a nodule is changing. And we've developed phantoms. We've distributed them. We've worked with RSNA and Kiba and now American Lung Association. And now these phantoms can be scanned within 5 minutes. You get back an answer right away, and you get fundamental information, mathematical descriptions of the acquisition system. And this chart on the bottom right, I just want to point out, shows here, whoops, that if you use diameter or volumetrics, whether you use one or the other with standard quality, they give you about the same answer in terms of separating cancers from controls. But if you use high quality volumetric data, images, the difference gets much, and your ability improves significantly. So this pushes us to gather more high quality data. And this is one example. If you know where the nodule is while you're scanning a patient, let's say on a second year, you can easily program the scanner, for example, to acquire much higher quality data. And this is an example we've shown in the past, but improvements can be had of being able to measure the objects like this by 600%. So at the end of the day, we expect that in the future, we should be able to improve the blue line to above where it is now, to something close to the green line someday, with AI, with productivity improvements, with many other things. I just want to point out the next two sessions, the next two presentations are going to be quite interesting. Why? Because we've had a chance to work with both GE and MEVIS to explore how do we create a protocol that is more optimal, for example, on GE scanners. And you may have seen on LinkedIn some posts, but I'm not going to speak for my colleagues here. They've got the fun stuff to present. But this is one of the first times that 3 industry groups who normally just talk about their own product are now working together and showing what can happen when we work together. And I think that's a really important thing for the future of lung cancer screening. So thank you.